Regarding tuberculosis, how tuberculosis infect human body. Tuberculosis gets transmitted by respiratory droplets, and these droplet goes from the oropharynx into the trachea. And the tuberculosis has a very particular cell surfaces, so it gets slipped from that mucociliary barrier and goes directly into the alveoli. In the alveoli, the body alarms the immune responses and warns the presence of a foreign material, foreign mycobacterium. uh, they get alarm the macrophages, alveolar macrophages. They signal the alveolar macrophages that there is a foreign material. So the alveolar macrophages engulf, come into the scene and engulf that Mycobacterium tuberculosis. And after engulfing, alveoli they get fuse lysosomal enzymes. They endocytose that particular bacteria or pathogen and fuse a lysosome with the phagosome and produce phagolysosome and destroy that bacteria. But when in the case of Mycobacterium tuberculosis, the after engulfing from the alveolar macrophages, the tuberculosis has a particular sulfatides, and these sulfatides are the surface glycoproteins, and these glycoproteins, they prevent the fusion of phagosome with the lysosome. So fusion of the phagolysosome, and in this way they evade the immune response of the body. So after the invasion from the immune response of the body, the bacteria present in the macrophages remain there, and it eventually proliferate, and the macrophage gets swelled, and the person is get infected from that pathogen. So after proliferation, the person get primary tuberculosis. And most of the patient, when they are immunocompetent, majority of the patients are very much asymptomatic, that they do not know that they are infected from a pathogen. And some are having flu-like symptoms. And at this point, the person is get infected. There is a presence of a pathogen in the body. At this time, if we do a PPD test, the PPD test get positive. We will come on this topic later on. So the bacteria is present in the macrophage and remains there and give the flu-like symptoms. So after some weeks, like post weeks, the antigen presenting cells take this tuberculosis and goes to the cell mediated immune cell like naive CD4 cells, and present this bacteria to the naive CD4, and in response to that presentation, naive CD4 get activated and release interleukin 12. We have known that interleukin 12 is very much important in the activation of T helper 1 cell differentiation. So they activate the T helper 1 cell differentiation, and they release interferons gamma. This interferon gamma then activate the macrophages consisting that bacteria, and the macrophages get aggregated, and also they differentiate into epithelioid histiocytes, and in this way they can wall off that particular bacteria. And walling of bacteria, there is an epithelioid layer in center, there is a TB, and also there is also multinucleated giant cell known as the Langhans cells. So the Langhans cell they releases the proteases to dissolve the protein parts. They releases a nitric oxide. They releases a reactive oxygen species, and all these all these try to kill this intracellular. There is intracellular killing of that bacteria, and eventually there is also a collateral tissue damage, and in this collateral damage there is a caseating necrosis in the lungs. So this is the process of making of granuloma, and this granuloma is present in the lower and mid lobes, and this granuloma present in these lobe known as gone focus. These gone focal bacteria and this caseating necrosis, they eventually goes to the respective hilar lymph node, and together with this node and gone focus, this whole complex is known as gone complex. And they eventually these all granuloma try to kill the bacteria. In some cases the bacteria get killed, in other cases it is viable and dormant. So the gone complex is eventually fibrosed, trying to heal, also fibrosed and calcify, and on CXR, on the X-ray, we can see as Ranke complex in the hilar area. So the hilar area gets calcified and form a wall of granuloma consisting of the particular tuberculosis bacteria. Most of the cases the bacteria it's get killed, and in some cases of patient, the bacteria remain there as dormant form, and also it is viable, but did not form any kind of problem for that tissue. So whenever the patient get some lung disease, the patient get some AIDS, also get malnourished or old age, this or immunosuppressant, or maybe a transplant patient on immunosuppressant, this Ranke complex, it gets reactivated. So the latent viable bacteria get reactivate, and this now the tuberculosis is known as secondary tuberculosis. And this secondary tuberculosis is typically happen in the upper well oxygenated lobes, because mycobacterium loves oxygen. It is an aerobe, so it goes particular to those organs which have the high concentration of oxygen. So whenever there is a reactive tuberculosis, or whenever the patient get old or immunosuppressed, the tuberculosis again activate, and at this point when there is a cell mediated immunity, there is also a memory T cells which are formed, and these memory T cells, when they get to know that the TB is now again activated, they, without any stimuli, they releases those cytokines which it releases in the past, and also forming the multi granulomas in the lung. And this again multiple granuloma formation, they coalesce and also they aggregates and also form the cavitatory lesions, especially in the upper lungs. And these cavitation is we can see it on the x-rays. So when the lobe get when there is a cavitation, and also the tuberculosis get uh, entry from to the invading vessels, it goes into the vessel, it can cause bacteremia. So now the tuberculosis is in the blood. So in the blood, bacteremia, or when the tuberculosis is in the blood, it has now access to multi organ. So it goes to the meninges and causes meningitis, tuberculous meningitis. It goes to the adjacent lung and also causing bronchopneumonia. It goes to the spleen, causing splenomegaly, and goes to the lymph node, causing lymphadenitis. It has a lovely place. Kidney goes to the kidney and causes uh, kidney infection, pyelonephritis, and especially the tuberculosis related infection with sterile pyuria. It goes to the adrenals and causes adrenals and causes Addison's disease. Goes to the vertebra and causes Pott's disease. So these are very much important regarding the miliary tuberculosis. And this is how a tuberculosis bacteria work, and how cell-mediated immunity, interleukins, and all granuloma formation, they all are get involved in this process of spread of this tuberculosis. So this is all about the mechanism of tuberculosis. Next, we will discuss how to diagnose and how to treat this tuberculosis infection.